Thank you very much. I'd like to talk about the treatment about the ISR regions. Here, I just, oh, sorry. ISR is a big issue for the endovascular treatment. Can we overcome the ISR regions? Yes, drug technology is very needed to overcome this kind of challenging situations. As everybody knows, use of the DCB is very good treatment. As already shown, there are many randomized control trials against the conventional laryngoplasty. Yes, DCB is a promising treatment. However, not so much a big data about the DS versus DCB for ISR region. Actually, this is my study. This is a prospective registry about the DS versus DCB. It's included approximately 30% of the ISR regions. As you can see, there is no interaction effect about the stenosis risk between the DS treatment and DCB treatment for ISR regions. However, there is no direct comparison data, so it's very difficult to discuss about these topics. Anyway, so we have to know that all of the ISR and ISR region is different. We often mention about this is a ISR, this is ISR. It seems a very similar region. However, for example, this is a Tosaka 3 ISR regions. It's includes much amount of the flesh thrombus. This is a subacute thrombus. After the CDT treatment, it's almost cleared. How about this one? This is also ISR regions. After the laryngoplasty and DCB applications, it seemed nice, but however, only 2 weeks later, this occurred again. All of the ISR region is different. Cause of the stenosis and occlusion is caused by different materials. We have to know the differences of the materials. We have to look into the inside of the stent. Of course, use of the IBAS is one of the techniques to evaluate the inside materials. However, today I'd like to introduce other devices. More detail provided us more detailed information of the inside of the stent. OFDI, probably some of you know these devices from the coronary intervention. OFDI or OCT more clearly visualize the inside of the vessels, 10 times higher resolution compared to the IBAS. Okay, if you look at the previous case, Tosaka 3 classifications, after the thrombectomy and thrombolysis, as you can see, some of the stent malposition were observed. Yes, this stent occlusion was caused by some of the subacute stent thrombosis due to the late acquired stent malposition due to the paclitaxial aortic stent. For such kind of situations, additional paclitaxial application sometimes make harm, may cause additional enlargement of the aneurysm. Therefore, in this case, I think relining with the covered stent is a reasonable strategy to prevent the recurrent occlusion, stent thrombosis. How about this case? If you look at the inside of the stent, as you can see, huge nodular calcification. Calcification is completely protruded into the inside of the stent. This is a very hard material. With only conventional value angioplasty, it's impossible to completely compress this kind of the huge lock. Therefore, I strongly recommend that use or jet stream or something we have to reduce the volume of the calcium inside of the stent. Yes, these occlusions or stenosis are completely different. We have to distinguish the materials inside of the stent. If you use the OFDI to distinguish the inside material of the stent, so Basically, some of the neo-intimal hyperplasia is classified into two categories: homogeneous pattern and non-homogeneous pattern. Homogeneous pattern is basically created by the fibroblast or something. It's some of the cell material. It's very hard. It's difficult to compress, but very good response to the some of the drug technology. In contrast, non-homogeneous type is often included a much amount of the extracellular materials, easy to compress, but it's difficult to respond to the drug technologies. It's completely different. This is a retrospective observation of small studies. As you can see, compared to the interwoven stent and paclitaxel aerating stent, it's included the Gilbert PTX and LBS stent. Neo-intimal pattern is completely different. Interwoven stent showed much amount of the homogeneous pattern. It means the most stable neo-intimal hyperplasia is frequently observed in the interwoven stent. However, in contrast, paclitaxel aerating stent, conventional neo-intimal hyperplasia is rarely observed. It often contains some of the thrombus or some of the extracellular materials, and also frequently observed right stent malpositions. Yes, in-stent occlusion and in-stent restenosis is completely different. This is a typical example of the super stent restenosis. We try to deploy the super stent for this kind of challenging calcified lesions. It's nicely deployed. If you look at the inside of the super stent, as you can see, even though implanted to the severely calcified lesions, no calcium progression were observed. Yes, super stent completely barrier the calcium progression due to the very dense stent strut. This is a very interesting findings. In the field of the PCI, the DCB response is completely different depending on the neo-intimal hyperplasia patterns. As you can see, if you see the homogeneous patterns, DCB response is very effective. However, if you can see the non-homogeneous patterns, DCB response is not so good. The one clinical question for ISR 220 peripheral artery disease were observed. Is there any differences between the neo-intimal hyperplasia pattern in each stent and the response, DCB response is different? Then I designed the Infinity ISR studies. This is a prospective collaborative study about the evaluation of the OFD and neo-intimal hyperplasia pattern for the in-stent restenosis lesions. And we also evaluated the DCB response for each lesion, we totally enrolled 123 ISR lesions, and we tried to evaluate neo-intimal hyperplasia pattern and DCB response. As you can see, several types of the stent were implanted. There's not, due to the time of the limitation, I would like to skip some of the detailed information. But anyway, this is the main findings of the presentations. As you can see, neo-intimal hyperplasia pattern is completely different depending on each stent. Interwoven stent showed more stable, homogeneous, fibrous plaque pattern were frequently observed. In contrast, in the drug aerating stent, much amount of thrombus were observed. It's a very interesting findings. Interestingly, interwoven stent showed stable neo-intimal hyperplasia pattern, but it's very difficult to compress with only conventional balloon. Therefore, neo-intimal reduction percentage is significantly lower compared to the other stent. The primary patency in overall cohort is, as you can see, it's a very busy slide, but not so. Some differences are observed in the homogeneous and non-homogeneous pattern. But unfortunately, due to the small sample size, there is no significant difference between the primary patency in the homogeneous and non-homogeneous cohort. interaction analysis showed thrombus is only one predictive factor negatively affected to the DCB response. Anyway, so we have to distinguish the each material with each stent occlusion or restenosis pattern, and we have to consider the best strategy for each ISR or ISO region. Thank you very much.